thank you very much for having me here at this very, very prestigious event. I just came in from Mumbai in the morning, and what I see over here is, I think it seems to be the microcosm of the globe, in fact. So thank you very much. Um, yes, I think I take all these compliments on behalf of Max, and I think it starts and ends with the trust which is reposed by patients at our hospital system. Today, our occupancy is at least 10 to 15% better than the next best player in the hospital system. One of the things that I want to point out is, AI seems to be the buzzword, of course, today. But 5 or 6 years ago, when we started our journey, we started bringing digital technology at that point of time to the core. And what you see today, what you experience, and you mentioned better outcomes and perhaps patient services, but that is what you experience. What you don't see is the technology behind it. And I think that is the true test of technology, and that will be the true test of AI as well. When you don't interface with technology, but the experiences are improved. Having said that, I think, like I said, we started this journey a few years ago. We started by creating a common-sized data lake for all the patients which have been through our doors over the last 15 years and which are doing so on a real-time basis today. Having said that, these were our attempts. We tried to sort of create a closed-loop system like Google, so to say, for our doctors and our patients. We, like many people, faced very early, very big setbacks, because when we used to do search results, we used to get zero results in the search engine, because it wasn't sort of native to the language, and that's stuff that we've been playing with. But having said that, I think the early days of AI are going to impact tasks rather than, although one is moving towards institutional, adopting it from an ecosystem standpoint, from inculcating it within the institution, so it becomes an intrinsic part of the institution. But I think today what it's affecting our tasks. It's affecting tasks of efficiency. We've already started doing predictive analysis of beds which are vacant and available and so on. It's working with on safety measures. I think those are early sort of wins that we have, especially with respect to patient stratification of the risks and so on. I think clinical support, it's data collection. A lot of time by clinicians was being spent in the past to collect data. Now a lot of that data is being collected through forms which are in our apps today. And you can speak to them. It kind of collates it in a particular manner. So the clinician actually spends less time in perhaps gathering history than in providing a little more value up the value chain.
Great, and I think Max, as you mentioned, there is this data lake that you have created is quite ahead in terms of digital adoption. And I'm sure when you would be starting, and this is a term that we use and see quite a lot, that adoption of digital in a hospital. So is that what is also happening on top of this large data lake and the EMR solutions that you have created on for Max? Is there like a AI adoption wave that is happening? And do you think, like, when the digital adoption happened, things such as NABH, ABDM, many of these things started coming up, talking about policy, talking about regulation. In AI adoption, are there any challenges, any things that you see that can help in this adoption to be much more faster? Or you see that people are just going all crazy on getting AI adopted in the hospital settings?
No, I think there is a desire all across. But having said that, desire does meet reality. I would say more than occasionally, and that comes in the form of failures, which are welcome. We quite welcome it actually, because the more you try, the more you will fail, and the more you will sort of have better outcomes coming into the future as well. So we've had a lot of failures, I can tell you. whether it is the longitudinal data of a patient or looking at, ICD-11 norms, tagging our data with respect to the WHO. I mean, we've been failing left, right, and center. We've been reasonably successful as far as ICD-10 is concerned, but I think 11, most sort of layers that are available in the market don't work. The ones which work are very, very expensive. So we've started, we've been in-housing a lot of this. So we're toying around with it. I have no doubt that the speed at which we are failing and the amount of failures that we have, shortly we will run out of all excuses and failures, and it'll be like Edison, right? You would have found out every way to fail, and I think perhaps the only way to succeed will be in front of us. So yes, there is a lot of enthusiasm, towards adopting it. We see this as a future. I think everybody does. There is, we of course have to be very, very careful, because unlike, let's say something like education, where if you're imparting perhaps incorrect information, it can be resolved. But this is healthcare. I think patient safety, data privacy, these things are right up there. We have very, very little, standard deviation possible in what we do. And so it requires a large extent of supervision, I would say. And perhaps it will continue to for years to come. Although it makes life easy for most, but it would, from at least from a clinical prescription outcome, it will require a lot more supervision to come as well.
Sorry. So is it now the priority for hospital? For example, when the digitization adoption happened, it used to be a priority for CEOs that, okay, you have to make sure that all the billings are online. You have to have all the JCI discussions and UHID created and so on and so forth. Is this a priority today, adopting AI at hospitals and as a KRAs for your CEOs or operators? Is that what, has AI reached that level today at hospitals?
No, I think clearly it has, and it's really out of, I think, two sort of drivers that I find at least, and this is at a very, very at the outset level. I think one is the way the world, the consumer behavior itself is changing. I mean, a lot of the searches used to happen on Google. A lot of the searches now happening through different platforms altogether. And the way they sort of seek, whether it's thought about your website or, when they're looking at, if you simply ask which is the best cardiologist in Delhi, there was a different way of people reading into that earlier, and there's a different way of people reading into it today. So you have to, whether it's your collaterals, whether it's your digital assets and so on and so forth, you have to make those changes. Information, I mean, if I look at ESG, if I look at investor ESG, how do I improve my ESG score? I mean, it's like an encyclopedia out there, right? You just ask it any question, it tells you to do so. How should I present my annual report? How should I present myself? I think, pretty much, it is intrinsic to now everything that we do from that standpoint. Second is how can I use it as a tool to improve efficiency? And these are low-hanging fruits. I'm talking about the low-hanging fruits before we even, kind of, absorb the entire ecosystem or create that ecosystem or participate in that ecosystem. Make it a part of institutional habits, right? I think even prior to that, when we're looking at it as a task stage, how is it that I can improve? Now, if I have a particular waiting for my patients, okay, how can I do predictive analysis of room availability? When I'm looking at discharge, how can I sort of this thing? When it comes to patient summary, how do I unlock the time that my doctors spend on patient sort of history and so on and so forth? That all improves efficiency, all improves outcomes, see, eventually, the lens we are looking at it from is efficiency, is accessibility, is safety, is clinical support, and finally, to the experience.
That's, I mean, it's quite a bit of breadth that you're looking at AI, and a little bit more on generic terms. Everybody says that technology is moving very fast, or things are changing so fast. AI is also changing so fast. And we also keep doing that. Like, we want our businesses, our operations, our sales also run very fast. is more your internal feeling. How are you feeling? Are health institutions moving as fast as the technology is moving? Even people in the organization, be it doctors, be it nurse staff, all of them are looking at it. And a lot of this is about India AI Summit as well, because government is looking for educating people on how fast things are changing, and we should all be ready for it. So, what are your views on your institutional readiness, people in your institute, and in general on this whole AI moving fast?
So I think first and foremost also depends on the institutional culture. We are very clear about one thing, that we have to be more sort of circumspect about it than anything else. We must go up the learning curve as far as AI is concerned. Things are changing very, very fast. We have close to 43,000 healthcare workers which provide healthcare. Um, that means there are thousands, if not hundreds and thousands of work processes. For us to adopt AI in any task means, you have to change huge amount of attendant work processes, even if this layer sits on top. Um, and having said that, okay, is there something else which is better out there? Is there something which will disrupt this further, and so on? Should we wait for something to be adopted by and large to see, so to see what the efficacy of that is, and see what the, see once it's sort of established before adopting it? To me, look, having the first mover advantage in this is not going to do anything, but getting it right is. I think because we can't afford to get it wrong. These are human lives, these are people. So I think there's a huge amount of learning within the organization which is happening. And I meet, you know, uh, phenomenal people across the board, okay, for various aspects. I think since the morning today, if I look at my sort of schedule, 30% of my meetings would be people from a technology background, pitching various sort of applications where our lives can be improved and outcomes can be improved and efficiency can be improved and so on and so forth. But, at the very least, you have to be very, very circumspect about what you're going to adopt and what you're going to roll out.
No, and I think you touched a very important point that we learned at EKA. We were earlier did a travel startup, me and Deepak. What we realized that in health, there is obviously innovation that people are looking for, but trust is the most important thing. I can bring a cool idea, or there could be a cool way of doing a diagnosis at a clinic, but I, as a person, would trust only the doctor that I have spoken to or I have been talked about. So there is this, and that's the reality that we learned when we started doing health. That yes, innovation is definitely important, but trust is key. And I think Max has been trusted over the years, uh, and to be very honest, we also don't know how to balance that out. The trust that has been created for institutions, for doctors, and now these technologies that are coming in, where it asks questions to the patients and gives relevant next suggestions. This trust factor is kind of getting a little sort of changed. Any views that you have, especially when it comes to uh, people trusting doctors, to AI, to institutes, any change that you see, and even doctors looking for AI solution, and whether they feel that this is right now not as good?
So, I'll give you one example. At most hospitals, at least um, once every couple of months, you will have a patient who will come in, okay, with a pain in the chest. You do the ECG, and the ECG to the doctor seems sort of normal. He speaks to the cardiologist, okay, and the cardiologist says, okay, I don't see anything wrong with it, and the patient is sent home, and he has a heart attack, right? Because ECGs, although they're extremely, extremely common, okay, can be very, very nuanced. So expert cardiologist, okay, may be able to catch a particular movement there, okay, while somebody else may not. But and even the expert cardiologist on a good day may be able to catch it, on a bad day not, right? Now, uh, I'm not saying AI in its sort of this thing is complete, but when a patient comes to ER, okay, I think it's absolutely necessary to use that tool, okay, because if that tool says requires admission, okay, whether the patient doctor sees it or not, admit him, okay. Look, by the end of the day, you may admit 150 instead of 100 actual patients, but don't let that one go. I think that's the important thing. You're able to, if you're able to use this as an assistive tool, to augment your capabilities. Okay, and I think that is what is emerging today. I think it's a little too far out to say whether it will replace the clinician or not. Okay, but I think right now, clearly, that is a very, very essential tool that you can use. And let's start with safety before we go to efficiency or anything else. Um, you know, so I think a very, very simple example like this, okay, and it depends, it starts with leadership, moves to institutional sort of habits, okay, to be able to adopt something like that, change your work processes, because the umpteen amount of work processes which have to change. Okay, a doctor, when a patient comes, where do you move? When this sort of ECG report, you move him to the cath lab, okay, and which is a 13-minute sort of this thing, but that's also preparatory time, right? You're doing it within the golden hours. Do you sort of move him into, the ICU? How do you sort of interact with the doctor? You have to call the doctor. Let's say it happens at 3 o'clock at night. Okay, the cardiologist has to come from his home and so on and so forth. So the entire dance starts, right? Yeah. Okay, but you have to make sure that, you can use this tool to err on the side of caution. But I think at the very least, that's what you need to do today.
And I think you touched upon like this complex healthcare process, and when we look at it from a technology perspective, this is what AI can solve for these extremely complex process that today there's a multiple human touch point, very simple, such as doing an emergency call to a specific doctor with giving all the respective summary, which today can be optimized, which can save lives. So that's the sort of things that we keep discussing about during our board meetings and discussions. But a lot of these, and maybe health and non-health as well. What's your view? How the next 5 years, next 6 years? Yesterday there was this conversation with Sam where AGI will be there in by 2028. What is your view on how next 3 years to 5 years? Now, we can't even say a decade, right? It seems like we don't know what all will happen in a decade. But how do you see next 3 to 5 years changing in your hospitals or in general healthcare?
I think dramatically, adoption of, and it's not because, hospitals or healthcare providers desire it. I think it's becoming absolute necessity for the country. One of the things, and perhaps one of the major things which propels our country forward, is the demographic dividend. The average age is 29, 28, 29, whatever. But make no mistake, for 10, 15 years down the line, okay, it will be very, very close to the European age. And that's the time people will require medical intervention. There just isn't enough infrastructure and doctors available in the country. Okay, it's barely sort of, it's actually not even enough for the population today. I can certainly tell you 15 years down the line, there isn't enough infrastructure which can possibly be built. There isn't enough money over here. Or, I mean, we're just behind the curve a little too much, right? And if we have to solve this equation as far as healthcare is concerned, you have no choice. But it has to be about predictive health. It has to be about, before even patient comes to the hospital, falls sick, to be able to predict that he is going to fall sick and make amends there. Reaching out to people, unclog the hospital infrastructure, home care, and so on and so forth. Okay, be able to replicate capabilities, skill sets of doctors to be able to take them to patients and so on. I think all of that is a necessity. Without that, we will fail the future generation. So there's no question of us. I think this is here. I mean, the future is here today.
Yeah, and especially the whole vision of making India a developed country, we have to leapfrog, and many of these technologies can help us in leapfrogging the way you were explaining. But thank you so very much, Abhay, for your deep insights. I think we all love Max and the the kind of work that you are doing, and we see more and more AI coming together at Max to solve for doctors, patients, and all of us. Thank you very much.
Pleasure is entirely mine. Thank you. Thank you so much.
Thank you, Abhay. And Vikalp, I just request you to present a token of memento for. We now move to. We now move to our panel discussion, which will be moderated by Deepak. States of impact. He has shaped landmark policies including India's National Health Policy 2017 and advised institutions such as the UN, WHO, World Bank, UN's IGF, Dynamic Coalition on Digital Health, among others. We welcome you, sir, onto the stage. We have with us Tanvi Lal, Ms. Tanvi Lal, Director of Strategy at People Plus AI, an initiative of the Ek Step Foundation. Her work focuses on scaling data and AI-enabled products for public good, with an emphasis on adoption, usability, and impact. Tanvi holds an MS in Biotechnology and Management from Carnegie Mellon University and an MBA from UC Berkeley, Haas School of Business. We next have Mr. Nikhil Dongri. He is a 2012 batch Indian Railway Personal Service Officer and currently serves as Director IT at the National Health Authority, where he leads the technical architecture and implementation of flagship national initiatives including the Ayushman Bharat Digital Mission and Ayushman Bharat PMG. We welcome you, sir. We have with us Ms. Padmini Vishwanath, researcher at the WHO SEARO, Southeast Asian Regional Office, bringing a regional lens to health equity, digital health policy, and evidence-based transformation in low and middle income countries. We welcome you, Padmini. And last but not the least, we have Mr. Jigar Halani, Director Enterprise Solutions Architecture and Engineering at NVIDIA South Asia, a 20-year technology veteran driving innovation in supercomputing, big data, and AI infrastructure, and a trusted advisor to government and industry on AI strategy. I now hand over to Deepak to lead the panel discussion.
I think we are short of space, so I'll manage standing high. Thank you very much. It was a great session, Vikalp and Abhay. He just left. We have short of time, so I will try to leave maybe 5-10 minutes at the end for everyone to have questions. I will like to start this session with Dr. Gupta. Dr. Gupta, we were talking last night. You were instrumental in defining the whole first white paper around ABDM. How did it all started? There is obviously a lot of progress from when you conceptualized way back in 2019, 2020 to today. What do you really think has really worked towards seeing the reality, and what are the challenges? How do you see going forward, how do this whole documentation moving from between patient and interoperability will start impacting the clinical decision making for the physicians going forward?
Thank you, Deepak, and thank you, Vikalp, for this wonderful session and giving me the opportunity. So it started actually in 2014. It was in BJP's manifesto where I wrote, and then in National Health Policy in 16, and eventually when I was advisor to Health Minister. So, firstly, we should compliment the ABDM team. There is no precedent. There is no precedent to create records for a billion population. How do you go about doing it? But I think people like Vikalp and you, every time you take a bold step, there are naysayers who will say, "Bijli nahi aati, aap kaise karoge?" Today we have 860 million ABHA IDs. So I think if I look at the reality today, and I know I'm sitting on the right of the director IT. We have created the digital infrastructure. Now we have to leverage that to empower the people who are going to use it. I see a future where we will not have people using multiple schemes. That was our biggest problem internally. I can tell you why this got, created, and there are more reasons too. But eventually, technology will allow us to optimally use resources, to clinically be precise in treating people, remove redundancies, and also my boss, who is still the Union Health Minister, we agreed fundamentally it will be tough to send doctors to rural areas. They study for 12 years to make their lives better, not to go. Of course, we want them. It will take time to have that infrastructure where they can stay in rural areas. But we believe that digital health, digital solutions will be able to leverage this backbone that we have created to serve people in the areas where they need them the most. I think that golden hour to platinum minutes to, I think, finally what I believe will be the digital health standards where in a minute you could get to what you need, at least for primary care. So I'm very optimistic, and Vikal was right, the decade is not, we used to talk decade at 2013, 14, now we talk 3 years max, few months is better to talk. Yeah. So I think it's time where we should be really optimistic of the vision that we were able to build thanks to people like who had implemented. We had COVID at our hand, when we looked at 2.2 billion people, getting vaccinated, not calling up people, just going to the app and getting it done. So I think the creators are in the room, the implementers are in the room, so ideators don't need to worry much. Thank you.
Thank you very much. That's a great advice. So moving to your left, Nikhil. Nikhil, you guys have done a phenomenal job in deploying adoption of ABDM in public sector today, but we see a lack in the private sector, definitely. What have you been learning? How do you think this whole learning of ABDM deploying at a large scale PSU, where obviously there is massive load of patients walking in and very limited physician and staff to support. Digitizing appointment is in a great way. How do you see it going forward, moving into private sector? How do you see it going forward, getting into the workflows even deeper, which will really help better outcomes?
First of all, thank you, Vikalp and EKK team and Deepak for inviting me here. What I can say, though AI models, whatever we see, so the model is dependent on the data we fed. So the models for health specific, you need context rich data. Generally, it comes from the big corporate hospital generally. So what ABDM did made a rail that whatever the foreign models which cannot be successful in India, so where the domestic SLA models and nano models which can be developed by EKK or other health startups, where ABDM created the federated architecture, where the model can go there and they can be tried. Because the simple making algorithm doesn't make a solution in the health sector. Right, just now as the max safety is very much important. So what is missing in the foreign models is which is not tried in the Indian data, especially we can't neglect the population, the rural population, small hospitals where most of the people go there basically. Where ABDM created a HMI solutions, where we have access to the longitudinal records of the patients, where our Indian models can be tried and where we can get the success actually. The ground is fertile enough right now to pitch in for the Indian startups to come in and train your models, especially because of federated architecture, you don't need LLMs. You just need SLMs and some random models to come and do it, so that the models cannot be biased, because the biasness I can't see only from the technical angle. Here you have to keep both clinicians and technologies, so that the context-rich data is available from across the India and across the population, where the subject is the billion clinical realities, and the AI model should be not only transactional, they should be conversational, where the literacy rate is very low. So now is a fertile ground for the Indian startups to come in and show the brand value of the Indian startups. So where I can see it. Thank you.
Thank you very much, Nikhil. Insightful. You touched upon cloud infrastructure, and we have Jigar here. So Jigar, cloud infrastructure has made AI scalable, right? We all are using, everyone's using Chat GPT today. Infrastructure, sovereignty, and trust are, hot themes. We've been hearing about these words for last 5 days, like I don't know, n number of times. It becomes super, super relevant for health, as we heard in the last session, the trust. How do you think the models or the companies building in India brings that trust factor so that physicians and the operator like Abhay would trust those solutions and then start implementing, which will really help, people like Nikhil in building those models for the country?
So I think it's a deep question, right? Trust has many aspects, if you ask me honestly, right? Trust in my language could be the most accurate results, and I'm happy because I'm a fast-moving guy, IT professional, right? So we are known for it. The event gets over today, and Monday we are back to work, and we know we are going to hog again for next 5 days to make something better and bigger, right? Trust for my mom could be a very different storyline, right? Because for her, everything on priority line is health, nothing else essentially, right? For me, plus or minus 1%, 3%, 5%, 10% is also okay. For her, nothing is okay, right? And trust for a mother who has just a newborn in her hand, it's going to be completely different, right? So I personally feel it has many layers, but a fundamental layer, if you ask me honestly, model builders, what they're trying to do is trying to still accumulate the knowledge which is still available on the web, right? What we haven't gone back, and that's where I would borrow, if India is achieving these numbers, which I was not aware. I knew ABBA pretty well. I have registered myself as well, although I have not used it yet, but I am a registered user. I want to myself get enrolled into every scheme that government is coming up with, just to make sure that to understand where all connectivity is possible, essentially, right? But
don't use all schemes.
I'm not even availing one. Yeah, but I'm saying that once we have this data, how do we make use of this data better so that I bring not just the context of India, which is so important, and what Ekakar is trying to do just on the language side of the story, which we all understand that language is so important to us. But imagine the environmental changes that I have from place to place, and basis which the changes that I have in my body structure, and basis which what medicine helps me better, and so on and so forth, right? It has its own subsequent chain of things that is there. How do I bring that data more into the ecosystem? Thereby I make those models more and more efficient, better, and in the lingo of what India understand, not just in language, but also in the lingo of health, which is impacting that particular. Like for example, I come from Gujarat, but I stay in Bangalore. I know for sure that environment is not suitable to me, right? And I keep sneezing for the pollen reason, of course. The moment I go back to Gujarat, I'm absolutely normal, right? Whether it is extreme cold, whether it is extreme hot, it's raining, doesn't matter at all. I never sneeze.
I think things works in Gujarat.
I come Delhi, I don't get sneezing at all, right? I'm just another example, right? So how do I bring that data more into the ecosystem, number one? And then number two, how do I train those models more efficiently and serve them back to the users? So that's one aspect of it, right? The second aspect of it is, I think, unlike language, in the healthcare, we need a very large momentum of citizens to participate and help us to have lot of feedback ecosystem in what they are pursuing from these models, which they are inferring it, right? Like for example, in your solution, which I've seen the demo because now it's been n number of times in the demo booth I've seen this. If a patient is talking, right, and going through your recordings, let's say, which he or she has just done, for him or her, it's the most important thing. For the doctor, it's like the next patient, right? How do I go to the next? But the patient will definitely go back and check the recording. Patient will definitely go back, as we all do, and for the rightful reasons. We check the second opinion with the doctor, right? But that information is only with me. What did the second doctor told me, right? I check with you as a doctor, and then I say, all right, it's a big operation. I should take a second opinion. And I go to her, I take another opinion, and then both they say the same thing, and I then still go Google, right? And I take the opinion there, and I say that, you know what? Looks to be that I need to get operated. But थोड़ा wait कर लेते हैं. And then 5 days free consulting है, चौथे दिन फिर जाएंगे डॉक्टर के पास. such 4 year questions hai. Right? So I think the user also need to put the feedback back in the ecosystem by using these models and then getting democratized it, right? I think that's how the trust layer is going to, this is at a very high level, right? Policy level, things are going to be very, very different, and I'm sure it's a topic by itself. Some other day, we'll work on it, and I'm sure we will thrive as well.
Thank you very much. Right. This Google Doctor has been very, very popular in clinics. When we meet a doctor, they hate it. I have seen a board many, many times outside the physician's cabin. No Google Doctor, please.
Yes.
Okay. So we discussed. So next question to Tanvi. We've been talking about private hospital infrastructure. There's a mass high quality infrastructure available in the country with really great physicians. On the other side, we have PHCs, massive pressure, less number of physicians. How do you think, builders, when they think of building solutions for both of these spectrum, like these very, very different, should they think of a single solution? They think of two different solutions. What do you think, how going forward?
Yeah, so at People Plus, which is an initiative of AkeStep, we do a lot of analysis on what are the adoption trends and for high need populations. So for basically for people who are building in healthcare, education, agriculture, right? What's the uptake? Who's building what? Who's not taking third-party solutions and trying to build internally? And there are a couple of points that have emerged in that thesis. I think the first is because AI is meant to be personalized and context-specific. It can deal with multilinguality and voice. There's firstly a lot of opportunity to bridge some of these inequity gaps that exist. So the first thing is that today you can imagine as a builder solutions that are in some very, very regional low resource languages for the different beneficiaries, and you can design them to be voice first, which in a way is inducing trust because now they are speaking to someone and they're just not reading off an answer and they don't know who's behind that solution. So the first aspect is that AI is meant to be personalized. So when you're building solutions, or I'm going to go a step further, I'm going to say it's beyond a solution, it's a transformation. You can create very customized transformations. That's number one. I think the second thing over here is that when, because it's a very fragmented value chain, right? In the case of healthcare, like someone is paying, someone is using the technology, someone's ultimately benefiting from it. What we've realized is when you're designing these transformations, a big part of a builder's journey is not just making the tech stack, but spending time with people who will be adopting it, educating them at different levels to explain how this tech could get consumed or improve their life, right? So many times, and there are 700 plus healthcare startups in India who are doing all kinds of pilots and demos right now. And what we've realized is that the demo phase goes really well, like 3 months, 6 months. You can get, because there is, adopters who could be hospitals or other institutions, sometimes play from a place of either fear or hype. Like, I want to be aware of what's going on and I'll do the demo. But after 3 months, this is just going to be a side window on my browser, which I never go back to because it was never thought of as a solution that I would embed into my workflow. So you have to think from the start of this as a journey and not just a one-time switch, that I get that one-time contract or that one-time demo and imagine that that will convert into some kind of impact. Now, to build that trust, it's very different in the private hospital, which is maybe much more urban, much more aware of what's going on versus a PHC, right? And the people in the PHC. So I think a tech stack and the solution is one piece of it. But when we're designing the transformation, which comes with education, awareness, trust building activities, creating safety and maybe feedback and evals that make sense for a PHC versus a hospital, which might be very different. So when you're thinking of the transformation stack, it has to be very different. And transformation is about much more than tech. And I think that's where people should be spending a lot more time as builders. It's just not about cracking that first pilot or that first deployment, but saying what will it take to go from pilot to population scale, right? Like what will that take? Because that is a very different journey. That's a systems journey. That's not a tech journey, always.
No, that's super helpful. Continuing the same discussion, Dr. Gupta, when you look at policy making, do you look at these two segments very differently, or you think when you look at policy like private sector, PHC, you think health one single sector, or do you start defining, saying, okay, how will it work in public, how will it work in private sectors?
So if you look at the national health policy, this is the first time where I actually wrote the line, both for private and public sector. Till 2002, it was mostly written and even implied that it was only meant for public sector. I think if you really want to deliver care, you have to break that barrier between private and public. That's how you will deliver care. When patient has a problem, he doesn't see whether it's a private or public should I get it. It's the first hospital they get it. So I think that was the thinking behind it, and that's how the policy is like.
Oh wow, that's great. Learn something. I'll move on to Padmini. From your regional vantage point, how should AI system be designed differently to reflect the diversity of contexts, capabilities, and care related across countries?
Yeah, thank you. First of all, thank you so much for having us today. WHO is very glad to be representing the work that we do, and listening to my co-panelists. It's interesting to hear about the importance of tailoring, because interesting and a little how do I say anxiety inducing for me, because the work that we do is on the other end of the spectrum, which is how do we create norms, right? How do we create norms and normative guidance to ensure that AI is equitable and moving in the right direction. And so when I'll talk from the regional perspective, and of course we work with 8 countries across CRO, and all of these countries and systems are at very, very varying levels of digital maturity, right? But what we often find is the AI tools are developed for the most advanced, most connected tertiary institutions, and then adapted later for the most more remote settings, right? But we are finding that some of the countries, pilots are looking at reversing this logic, which means that we start developing readiness frameworks for the most remote settings, understanding the frontline capabilities, device availabilities, all the factors that matter in AI readiness, developing a framework for that level of remoteness and then scaling it. And when we do see that in in contexts where we do that, there is higher provider trust, there is more equity. So I think that is, from our experience, we feel that maybe we need to slow down a little bit and look at how we can modernize existing legacy systems rather than kind of building on and adding new systems. Yeah, I'll stop there for now.
All right, that's really insightful. We've spent, all of us, like last 1 week spending here. So I would like to ask single question to each one of you here. What has been your great one thing you've learned in this, which you think has started creating some impact in health? One thing you've seen in the last 5 days which you were not aware of, and saying it starting some early signs of success in the health ecosystem, if there is any. So maybe starting from
I'll go first. I think voice. It's a common factor. I think it's horizontal, not vertical, but it's very, very important for the country, right? If I understand what Tamil doctor is speaking with the patient and convert that into Hindi and have that deployed in Delhi and Gujarat, I think I'm home essentially, right? I'm solving many problems for years together that has been prolonging in the country essentially. I think it's by itself is a reward to the country, and we should be fully leveraging it essentially.
I think one thing that I'm very happy about is the mindset change. That's going to be the biggest thing. It's not a technology problem, it's a mindset problem. And that's what I have seen every single person, talking to. They started more believing in the fact that, the time has arrived.
That's great.
I will tell 2 things. One thing is broader. So I am very happy that lot of discussion is going on about AI. So for any technology, anything to inculcate into public, the thought process is very much important. That impact summit, it created that impact to discuss things on AI. Basically, now everyone will discuss on AI. Like you, be it a very rickshaw puller to the CEO, the discussion is happening. That is very, very much important to build systems, that thought process. Second thing, I visited few of the specialist startups. So I'm very happy to see some startups are doing really great, like Eka Scribe. So where that ABDM can use basically small clinics to reduce the burden of the clinicians from the non-clinical work. So, and there is one company, and they are doing very great work on data anonymization. Because for models to train, after the advent of the DPDP Act, so the data privacy and patient consent is very much important. So they are working really good in India. So I'm very happy to such companies are there and they are doing really wonderful. So I'm very felt. Thank you.
I think for me it would be the emphasis on AI-ready data systems, because this is across sectors. Everyone is realizing that AI is only as good as the data, both at the model and the application layer that it has access to. And I really want to give you guys credit for that, because you are pioneers in terms of putting out data and making it available through that MCP server that came out. In fact, we cite that as an example. We are working very closely with MOSPI right now, and they want to make their statistical data sets available to the world. They have put out their first MCP about a week ago, but just the fact that you are, institutions are just not extractive when it comes to data, but they want to give it back so that others can build on top of it is very important. So in health, it's crucial that that happens, because otherwise there is no personalization happening.
Yeah, Padmini?
So I would say, I think so far, we have looked at a lot of quantitative measures of adopting AI in health, diagnosis, accuracy, number of patient visits, etc. But I think this time round, we are seeing more discussions around the qualitative dimensions, right? Empathy, dignity, care. And, it's interesting because in one of the pilots we are conducting on palliative care, we didn't even think about it, but a caregiver and a patient, palliative care patient, visiting a nurse, that's their only source of human connection during that week. And so how does AI kind of change that dynamic of caregiving, right? And those little moments they spend together in the clinic. So I think the increased conversation around this and just acknowledgement of not just the quantitative but also the qualitative dimensions is something that I'm personally really looking forward to.
No, thank you. The objective of this question was not to get the promotion for ECA, just a disclaimer. I will. No, but thank you. This was super insightful. Audience, any question?
Sir, I just had a one question, right? You said voice language translation AI. So that mostly 90% they are on the cloud. So that needs to be on the edge only or on the cloud or hybrid?
No, of course. I think, where do you use ChatGPT? Do you use ChatGPT?
Yes.
None of the servers are hosted out of India.
No,
Right,
I'm just saying
so-
this cost factor is also
Cost?
there, and
I think
they have data privacy also there. So and so
the moment you add cost, as long as it is in India, I think we are home.
okay.
I don't think so we could be ever cheaper.
So I was just asking a suggestion from you. So like, what model should, like someone who's creating such solution for voice and translation multilingual? Let's just target 22 languages. So where should the MCP or the inference or the ChatGPT server should be hosted? On the edge, on a gadget, like a mobile phone or something audio recorder, or hybrid? with
I
a
would
local-
say depends on the use case.
Okay.
If you have a very particular use case, very tiny one in a remote place, edge would be the solution. You don't have a choice. You will lag behind the connectivity and few other aspects as well.
It will synchronize once a month or once a week or once a day.
No, voice is something you need to have connectivity in play.
Okay.
You can't be having offline things. That's my view at least. People are trying. I think Savam had something on
So
mobiles.
I think 90% we should go for connectivity with the cloud or the server.
Yes,
Even if it's a local India hosted server.
that's correct.
Okay. Got it.
Yeah, there's one at the end. Rahul, there's one at the end.
Hello everyone. We have seen a lot of stalls in the expo showing AI-powered documentation and diagnosis. I'm a dentist and I am currently pursuing MBA Analytics. So I'm curious how far this AI, Indian-based AI tools are relying on Indian data rather than global data sets.
Depends on what they're claiming, that's first. So, and the other side, I also represent the Mayo Clinic strategy in India. So as Mayo Clinic platform, we are opening in partnership with some of our data sets for to look at, but also collaborating with hospitals inside to leverage each other's anonymized data sets. So I think important point to note is the culture of data is missing. I mean, we still have to get the culture of data to get to have those AI systems that are based on Indian population. I think this is still far away. I think with ABDM sitting next, though we have 860 million hub IDs, but if the number of records on ABDM, if you check, they are not what we want to be. So I think we're still not there in terms of if someone makes a claim, be careful.
Thank you.
That's great. We talked about, what we really like, what we've seen the change fundamentally. But do you guys also think there are still few items where we're lacking behind as a country, as a health, where we should have been, already seen, or you think we are on the right path? And if we are on the right path, then what do you think will be the great outcomes in next 3 to 6 months to a year? I don't go beyond a year. In the terms of how health is being leveraging AI in the country, whether it's PHC or a private hospital.
I'll answer is very frankly, even at the cost of upsetting. See, the issue is not about the usefulness of technology or the use case. It's about ethics and doing the right things. Most of the people are not using, not because the UX, UI, technology, outcomes, everyone knows that. How many doctors would actually want to tell what they charge for a prescription, how many prescriptions they make, and why they write 3 antibiotics for one case? So I think it is about regulating that unethical part. The way they were able to crack it, you'll be seeing the mass adoption. The challenge lies in the medical practices and medical ethics, not on the solutions per se. Otherwise, we would be the most adopted nation in terms of digital technologies.
Last night, we were having this conversation where in China, I was surprised to hear this, that on the real time, when a physician is writing a prescription, there's a data going back, and if there are errors, it's coming back, and the doctors are getting flagged if they continuously do this thing. And then that's the way, one way of controlling what you really said. And think of us, we are still in metros literate, but think of people in tier 2, tier 3 having 3 antibiotics at the same time. It's crazy.
Being literate in metros. I have seen in Bombay a chemist saying, azithromycin le lijiye, theek ho jayega.
Yeah, we pop up.
Once come about cough and saying azithromycin. So I think it's an issue about practice, medical practices, good pharmacy practices, good prescription practices to follow. I mean, he could have given a cold and a cough syrup, that would have made him money too.
Yeah.
But wants to give azithromycin.
That's Nikhil, you had a point?
Just want to add to Gupta ji, and she asked one question: how many models are training on Indian data? So you said that where we are lagging behind. So I want to say the behavioral change is very much important. So we have solutions. Even we gave with CDAC, we gave one issue light, which is almost free to small hospitals, and all the government hospital, including AIMS, having the HMI solution where they can create the longitudinal records. But some of the docs are not ready to do, because they said that we are very much accustomed to writing on the paper only. So still they are doing, and we are accepting. So where we are losing the context-rich data from the major public hospitals. So where we need some tough stands, because I'm now working in National Health Authority, but before I was in Railways. Now Railways totally stopped physical prescription, because they took a decision that no more physical prescription. They are doing only now online prescription, everything, even lab record, everything integrated. So they took one decision, there it ends actually. So we need some tough decisions, and also we need some behavioral change, where we have to go for creating longitudinal records. Then only we can give some context-rich data to the Indian startups, where our models can be deployed and trained. Then we can get benefit of it.
No, thank you very much. You've been a great panel. Thank you very much for all your insight. And
Sorry, in the interest of time, we'll have to wrap up. But before we close this session, a sincere gratitude and thank you to all our panelists. I request Deepak to just present a memento from our behalf.